professors, senior juniors, all the participants, and of course, special heartful welcome to our foreign speaker, Dr. Arunima Verma from Jamshedpur, India. I, Dr. Sagarika Sharmin, Assistant Professor of Surgery, Marine City Medical College and Hospital from Chittagong, feel honored to moderate the session of this night regarding breast cancer awareness. Now, I'd like to introduce our participants of the session. Our chief guest is Honorable Professor Dr. Kanuk Kanti Borua, Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University. Salam, sir. Our session is presided by Professor Dr. A.H.M. Tawhidul Alam, sir. He is the Honorable President of Society of Surgeons of Bangladesh. And the welcome speech will be given by the Secretary General of Society of Surgeons of Bangladesh, Dr. Noor Hossain Bhuiya Shaheen, Associate Professor of Surgery, Department of Chittagong Surgery, Chittagong Medical College Hospital, Chittagong. Now our speakers, according to the seriality of the topics, our first speaker is Dr. Tazdina Haq Khan, Registrar of Surgery, Chittagong Medical College and Hospital, Chittagong. Our second speaker, Dr. Arunima Verma, elected Chairman of Association of Surgeons of India, Jharkhand Chapter, India, Head of the Department of Surgery, Tata Motor Hospital, Jamshedpur, India. Our another speaker is Professor Dr. Salma Sultana, Professor of Surgery, Dhaka Medical College Hospital, Dhaka. Now the panel of experts, we are honored tonight to have with us with our liaison professors, Honorable Professor Dr. A.M.A. Mojid, sir, Professor A.J. M. Mustaq Hussain Tuhin, sir, Professor Saifuddin Ahmed, sir. So let us start. With due permission of our chief guest, I start. We all know that October is the month of pink. It is the month of breast cancer awareness, and pink is the color of this month. National Breast Cancer Awareness Month of America is an international health campaign held on October in every year. The purposes of this awareness program is to create the awareness about breast cancer, especially about the screening benefits of the early diagnosis of this curable cancer at an early stage, and of course to alert our general population about the physical, psychological, economic burden of this cancer when it is detected at advanced stages. Another purposes of this awareness program is to alert about the risk factors, about the genetic consequences, about the predisposition and preventive measures that few we have in our hands. Mostly we have to face it with the great courage with the early diagnosis of this cancer at an early stage. And another purpose of this awareness program and awareness month is to raise the fund for breast cancer, especially for the research purposes. So now I'd like to start the session. Our welcome speech will be delivered by our Honorable Secretary General of Society of Surgeons of Bangladesh, Dr. Noor Hossain Bhuiya Shaheen. Please, sir, go ahead. I request Shaheen, sir, to start.
Thank you very much. Thank you, Dr. Sagarika Sharmin, for nicely introducing about the Breast Cancer Awareness Month. We settled in this month in the 3 scientific session, the 14, that means today, 17, and also the 28. 14, 21, 28. We try to involve in this session in the various parts of the Bangladesh, also the faculty from India, the 3 faculties in 3 days from the Indian, and those who are fully associated with the dealing with the breast cancer diseases. So I am grateful to those, and I give much thanks to those speakers from India, especially today's speaker, Dr. Arunima. Thanks to participant involved with us in this session. And I request all of the speaker, panel of experts, chief guest to listen in this session and continue us with all the 3 sessions of this Breast Cancer Awareness Month. Thank you very much for hearing my topic. Thank you very much.
Thank you, Dr. Noor Hossain Bhuiya Shaheen sir, Secretary General of Society of Surgeons of Bangladesh. Now, as we have short of time, we should proceed the session, our discussion session. At first, the session is started by Dr. Tazina Haq Khan, Registrar, Surgery Department of Chittagong Medical College and Hospital, Chittagong. Tazina, her topic is surgical anatomy and pathology of breast. Dr. Tazina Haq Khan. Tazina, can you hear me?
Yes, ma'am. Can you hear me?
Yes, we can hear you. And
can I share my screen?
Yeah, we can.
You continue your session, Ms. Tazina Haq Khan. We hear you.
So she 1, 2, 3, 4 screen available.
Showing?
Yes.
Thank you. Assalamu alaikum and very good evening, my respected teachers and our foreign delegates, Dr. Arunima and my sirs. Welcome to our today's session, which is scheduled as breast awareness program, and my topic is anatomy and pathology of breast disease. As I'm introduced by Dr. Sagarika Sharmin ma'am nicely, so I'm going to start my topic. First of all, before discussing about the anatomy, I would like to give a focus on the embryology of breast, which is developed from the embryology, and multiple potential breasts are developed, but at the final stage, one breast is developed on both sides. And accessory breast is present in 1% of population, and this is the mammary ridge. And accessory breast can occur in any of these lines, and accessory nipples can occur in these lines. Now, what's the anatomy of breast? We know that anatomy of breast is broadly classified into breast parenchyma and breast stroma, and it is a modified apocrine sweat gland, and the parenchyma contains of 15 to 20 lobes. And these lobes are first from the nipple, it's divided into lactiferous duct, then divided into terminal ducts and lobules, and this fat and the surrounding ligaments are consisting of the stroma. And all the unit is the terminal ductal lobular unit, which is involved in the different type of diseases like benign and malignant diseases of the breast. And this is the histopathological slide review of normal breast, and this is the lobule, and this is the acini and fibrofatty stroma. And diseases are classified accordingly to the side of the breast. Now, what is the blood supply of the breast? We all know the blood supply of the breast comes from the lateral thoracic artery, internal thoracic artery, anterior intercostal, and posterior intercostal. And the venous drainage is corresponding to the arterial supply, and mainly from the axillary vein and internal thoracic vein. Now, most important nerve supply of breast, which should be preserved during our breast conserving surgery or mastectomy or any surgery we are undergoing for breast diseases. And these are the nerves. I will just give the surgical importance of this nerve. Lateral and medial pectoral nerve supplies the pectoralis major muscle. So we should be careful during dissection to preserve the lateral and medial pectoral nerve, and because if we are preserving the pectoralis as major and minor muscle, but we are compromising the lateral pectoral and medial pectoral nerve, then the muscles will not work properly. So we have to preserve this nerve also. And another 3 nerves which are preserved during mastectomy is intercostobrachial nerve, long thoracic nerve, and thoracodorsal nerve. And beside thoracodorsal nerve, there is thoracodorsal artery, and this is the thoracodorsal trunk. Now the lymphatic drainage of breast, which is very much important. And lymphatic drainage, mostly 75% of lymphatic drainage occurs by the axillary lymph node, and most of the breast cancer occurs in the upper lateral quadrant of the breast, and that's why most of the patient comes with the axillary lymphadenopathy. And there are other lymphatic drainage also, which can be in breast drains into the paraesternal lymph nodes, and some lymphatics are anastomosed with the rectus sheath, linea alba, and some diaphragmatic space. For this, some umbilical nodule is found in carcinoma breast, distant metastasis, which indicates the distant metastasis. Now comes the breast. The whole breast, we know all that during examination, we divide the whole breast into 4 quadrants, central quadrant and this 4 quadrants. Now, I would like to show the normal mammogram of a normal breast, but the problem we have to face that after 35 years of age, we prescribe the patient mammogram, but if the breast is dense breast, then it would be very much difficult for us to pick up the carcinoma or cancer site for breast. So for dense breast, we would like to suggest the ultrasonography. Now, these are the benign breast lesion. I won't like to discuss about this. These are some inflammatory non-proliferative diseases. And this is the mammogram of fat necrosis, which is a very important differential diagnosis for carcinoma breast. And this is the histological slide of fat necrosis. And this is another common pathological condition of breast, fibroadenoma. And here the mammogram shows the clear outline, and it is the pathological specimen, and this is the histopathological slide. These are the proliferative breast changes and proliferative breast diseases, atypia, and benign neoplasms. This is another picture of intraductal papilloma, and which is a more common cause of nipple discharge. Now, why we should hear about benign neoplasm? Benign neoplasm will be discussed later on by Dr. Onurima, our foreign faculty. But I would like to highlight why we should care about benign neoplasm. At first, it mimics malignancy in some extent, and it may develop in future breast cancer, and it is the more common cancer. And this is the data of last 1 year of our Chittagong Medical College Hospital, as we have a breast clinic corner here, and it shows that most commonly we have the 40% fibrocystic change. That is, the benign conditions are more common in our perspective, and fibroadenoma is 7%, cancer is 10%, and miscellaneous is 30%. And most of the patients, some patients come with 30% patient comes with no disease, but only their anxiety that they have something in their breast. Now, these are the common presentations of a patient coming from breast disease. They may come with pain, that is mustalgia, palpable lump, bloody nipple discharge, abnormal mammographic findings. And we usually say the patient, when they come with mustalgia, they become very much worried about them, whether they have carcinoma or not. We can ensure them or not absolutely, but if the patient feels pain, then carcinoma is less likely to happen there. Now, these are the malignant neoplasms of breast, and malignant neoplasms of breast is now in intense scientific investigations, and now advancements have been made in carcinoma breast conjoining therapy, reconstructions, and most importantly, screening is very much emphasized on the breast cancer awareness program, which is the main theme of our program in this month. And we have to also focus about the risk factors for breast cancer. And these are the malignant neoplasm, carcinoma in situ, invasive, special tests, Paget's disease, inflammatory carcinoma. And these are the mammographic findings of ductal carcinoma in situ. invasive ductal carcinomas showing speculated margins in the mammography, and in slide also speculated margins seen. This is another picture of Paget's disease of breast, inflammatory carcinoma. I didn't discuss all the malignancies, but some common scenarios, and we face that inflammatory carcinoma and chronic breast abscess or breast abscess very much mimics with each other. And most of our, with due respect with our surgeons, we treat is at breast cancer, but at the later stage of inflammatory carcinoma, patient comes with distant metastasis. So this should be kept in mind. And behavior of breast cancer is some breast cancer local recurrence, then it can go to the lymphatic metastasis that I have told earlier, and hematological metastasis by liver, lung, or bone metastasis. And these are some male breast conditions. They present with gynecomastia or carcinoma. This is a picture of male carcinoma. And most importantly, pathological factors for malignancy should be focused for our day-to-day practice, staging of the disease, grading of the tumor, margin of resection, and these are the receptor status, ER-PR, HER2, and mu. We know that ER-PR positive is good prognosis and ER-PR negative is bad prognosis. And these are some specific presentations for breast cancer, BRCA1, BRCA2, and P53. So these are shortly about the anatomy and pathology of breast diseases. Thank you for your patience hearing.
Thank you, Dr. Tazina Khan, Registrar, Surgery Department of Chittagong Medical College and Hospital, Chittagong. Actually, anatomy and pathology are the ABC of any type of surgery, which is nicely described by Dr. Tazina. Thank you for your strong presentation. Now, the second part of our discussion, which is enlightened with our foreign delegate, Dr. Arunima Verma, Head of the Department of Surgery, Tata Motor Hospital, Jamshedpur, India. She is also the elected chairman of Association of Surgeons of India, Jharkhand chapter. So I invite Dr. Arunima Verma, madam. Madam, please, can you hear me?
Yeah, thank you very much, Dr. Sagarika, and thank you for this opportunity. Can I start my screen share?
Sure.
Yes, you can start. Yeah.
So at the outset, I would like to thank the organizers to give me this opportunity to cross the frontiers and present before you this talk. And Dr. Tazina has very nicely elaborated on the pathologies, and she has set the stage for me. So the topic for me today is non-cancer breast diseases, its diagnosis and management. It is a very vast topic, but I would try to cover in brief, giving you a bird's eye view. So benign breast diseases are constituting almost 80 to 90% reference to the breast clinic and are 10 times more common than breast cancer. But it is an underestimated incidence because many females never reach the physician to consult for these problems because of various taboos in various societies. Up to 30% of these women who suffer from benign breast disease will require treatment at some time in their lives. And it is not because of physiological suffering, but many of them have got psychological disturbance because they live in the fear of malignancy. These patients may undergo unnecessary surgical intervention, which is not recommended. So why are the benign breast diseases important? They are important because they are much more commoner. They are difficult to differentiate from breast cancer at times, as pointed out by Tazina in many of her slides. The incorrect diagnosis and inappropriate treatment of benign breast diseases are associated with significant morbidity. So the surgeon has to be aware. This is just one slide on the breast structure and physiology to just set the ball rolling for the benign breast diseases. And the human breast has got 4 types of ducts. The type 1 is an undifferentiated bud-like structure, which is seen at menarche, and in nulliparous women it persists throughout all ages. It has got a high content of estrogen receptor and high rate of cellular proliferation. The second type is more complex with higher number of ductules per lobule. And these are the 2 types of ducts where the ductal and lobular carcinomas originate. The third type is seen especially during pregnancy and lactation, and it is more differentiated with less estrogen receptor content and has low proliferative activity and is most frequently found in Paris women. The type 4 is again fully developed acini and is seen during pregnancy and lactation. And these two types are responsible for most of the benign diseases like adenomas, fibroadenomas. So what is the most accepted classification of benign breast disorders is the aberrations of normal development and evolution, normally known as ANDI. And the concept of ANDI is based on that most benign disorders are normal process of reproductive life. And there is a spectrum that ranges from normal to aberration and very occasionally to diseases. But the definition of normal and abnormal is pragmatic, and the surgeon has to judge what it is. The ANDI concept embraces the aspects, symptoms, signs, histology, and physiology. So taking it briefly, it is divided into the 3 stages in a female's life, where between 15 to 25 years is the early reproductive life, where lobular and stromal development occurs and nipple eversion occurs. And when there is an aberration, you can have fibroadenoma, adolescent hypertrophy, or nipple inversion. When it goes to a giant fibroadenoma, gigantomastia, or subareolar abscess or mammary duct fistula, it is a disease. In the 25 to 40 years, it is the mature reproductive time where the cyclical changes of menstruation and epithelial hyperplasia of pregnancy are found. And when there is aberration, you land up with cyclical mastalgia, nodularity, and bloody nipple discharge. And disease-wise, it can be incapacitating mastalgia. Involution occurs from 35 to 55 years of age, and due to lobular involution, you can have macrocyst. And when there is ductal involution, you can have dilatation will cause ductectasia, and sclerosis will cause nipple retraction. These may lead to what is known as periductal mastitis or abscess. If the epithelial turnover increases, usually in this period, then there is simple epithelial hyperplasia usually. But if it is accompanied with atypia, then you have the disease. The non-ANDI conditions are also well defined, and they are fat necrosis and lactational and non-puerperal abscesses. So coming to them one by one, in the early reproductive life, we see most commonly the fibroadenoma, and WHO has defined it as a discrete benign tumor showing evidence of connective tissue and epithelial proliferation. And the hallmark is concurrent proliferation of glandular and stromal elements, and it is of 2 types, intracanalicular and pericanalicular. Clinically, it presents between 15 to 30 years of age group and is a rubbery, firm, smooth, or slightly lobulated, very mobile mass, commonly known as the breast mouse. Radiologically, you find an oval, isoechoic, or hypoechoic mass with well-circumscribed margin. The diseased variants, which we can call a giant fibroadenoma when it is more than 5 centimeter, multiple fibroadenoma when you have 5 or more in one breast. Juvenile fibroadenoma is a special type which is found mostly in adolescent girls, and it causes rapid growth, and it is more cellular than the usual fibroadenomas. The complex fibroadenomas will have the elements of adenosis and sclerosing adenosis, and these ones need to come out. So coming to diagnosis, it is triple assessment, which will be discussed by my next speakers, so I would not go in detail for them. So treatment-wise, ideally, less than 35 years, less than 5 centimeter size, managed conservatively by 6 monthly follow-up. More than 35 years, less than 5 centimeter, triple assessment, then close follow-up for the 3 monthly interval. Excise if the size increases. If it is more than 5 centimeter in any age, ideally should be enucleated. In the recent advances, we have centromen, high-intensity focused ultrasound, and therapeutic excision by ultrasound-guided vacuum-assisted biopsy. And this is a randomized controlled trial from India AIIMS, which shows that most of the fibroadenomas, about 31%, showed regression when 30 milligram was used daily for 3 months. And it was well tolerated, but it has been a 6-month study, so long-term studies are needed, and more studies are needed on this. This is a clinical trial which has been launched to assess the treatment of fibroadenomas with high-frequency ultrasound. And this is still going. August 2020 was the primary completion date. And by 2021, we would have better idea of whether we can use it for fibroadenomas or not. Looking at the ultrasound-guided therapeutic excision vacuum-assisted biopsy, this has shown that it is a well-tolerated method, and the lesion smaller than 2 centimeter can be excised by this. But you need to have a multidisciplinary evaluation, and decision should be made beforehand. But it should not be overused or misused. This is one of the giant fibroadenomas in a 40-year-old female whom I excised. It was about 8 centimeters in size, and she had multiple. The other fibroadenoma was also in the same breast. So both can be brought out by a periareolar incision by using the right technique. This was another very interesting case which I operated in a 13-year-old girl where the most of her breast was replaced by multiple studded fibroadenomas, and she landed up with a subcutaneous mastectomy. And unfortunately, because her breast blood could not be preserved, she could not have breast development. We have offered her plastic surgery for this. She has not agreed yet. Coming to phyllodes tumor, it is worth mentioning because it is a special type of fibroadenoma and considered as an aggressive counterpart because it is usually confused with that. It has got leaf-like fronds projecting into cystic spaces, most commonly seen in 30 to 50 years age group, grows very rapidly and at times can involve a large part of the breast, because of which the overlying skin can undergo necrosis and ulcers can form. It is unevenly bosselated surface. And despite, the most important thing is, despite its massive size, it remains mobile on the chest wall. It can be benign, locally aggressive, and sometimes metastatic. Treatment-wise, a wide local excision with a 1 centimeter normal margin is what is advised. But at times, because of the size, you might need a quadrantectomy or even a simple mastectomy followed by reconstruction. Another condition, adolescent hypertrophy. Here you have to have an objective assessment. Ideally, a breast should be 250 to 300 cc, but if it goes to in the category of 400 to 600, it is moderate hypertrophy, and it is gigantomastia when it is more than 1500 cc. There is gross stromal hyperplasia at the time of breast development, and you have to assess them based on guidelines, and you also have to take in consideration the general habitus, obesity, and the patient's own perception about the breast. The clinically patient presents because of embarrassment, and if it is actually in the pathological side, patient presents with discomfort and inability to perform daily activities, and here you have to give the patient the option of reduction mammoplasty. Nipple inversion is aberration of development of terminal ducts, which prevents the normal protrusion of ducts and areola. And here, because of it, you can have terminal duct obstruction, which leads to recurrent subareolar abscess and mammary duct fistula formation, which may lead to periductal mastitis seen in younger women. Now, coming to the mature reproductive life, in this, the most common and most incapacitating one is mastalgia, where you may either have cyclical mastalgia or non-cyclical mastalgia. In the non-cyclical variety, you may have a true non-cyclical breast pain or other pains like musculoskeletal pain or cervical spondylosis, angina, or cholecystitis. So usually, normally 2 to 3 days of premenstrual breast tenderness and heaviness every month is common and can be considered normal. But if the intensity increases to more than 1 week per cycle, then it can come into the pathological variety. And to assess this, usually this is a chart that you can use for daily breast pain charting and the intensity. Based on this, you can assess what kind of treatment the patient would need. It is also accompanied by nodularity, which is seen mostly bilaterally, and it is accompanied with the cyclicity of the pain. Symptom described by the female is heaviness and tenderness to touch, and it can radiate to the axilla and down the medial aspect of upper arm, which is very much, if it is on the left side, you can even think of vagina, but it is a referred pain because of the intercostal brachial nerve. Clinical condition is painful nodularity of Andy, and pathological counterpart is usually called fibroadenosis. The non-cyclical mastalgia do not relate to the menstrual cycle and can be present in both pre- and post-menopausal women. Usually they are unilateral, but may be bilateral, and they're usually well localized. And they may even have trigger spot zones. In this, the patient describes it as burning or drawing pain. And the pain is of lower intensity, and the nodularity is less prominent than in the cyclical pattern in these patients. So looking at the armamentarium of treatment in these patients, you have hormonal manipulation and non-hormonal agents. The hormonal manipulations are danazol, bromocriptine, tamoxifen, and LHRH analog. And non-hormonal are NSAIDs, iodides, and like evening primrose oil. Looking at a systematic review of current understanding of mastalgia, it says that breast support garments and diclofenac gel are usually effective. Surgery is not helpful. Severe cases, you can use the anti-estrogens like cetacromin and tamoxifen. And in those refractory mastalgia, you can use the LHRH analogs like goserelin. Vitamins, diuretics, and evening primrose oil, these are obsolete and actually not effective. They are usually placebo effect only. Coming to our next very important pathology, that is the nipple discharge. It is defined as a spontaneous efflux of fluid from the nipple, and apart from the physiological function of puerperium lactation. So nipple discharge can be physiological galactorrhea, secondary galactorrhea, or it can give you greenish or grumous colored opalescent and serosanguinous and watery. Looking at the relationship of discharge type and pathological diagnosis, if it is blood related or bloody, serous or watery, it is usually because of hyperplastic lesion, which includes hyperplasia, papilloma, carcinoma in situ, and invasive ductal carcinoma. So the concept that watery and serous discharge is not carcinoma is wrong. It is not that blood related is usually carcinoma. So even the serous and watery discharge, you have to be very careful. Colored the opalescent like green or milky, they can be in ductectasia or when there are cysts. Milk is physiological or if there is galacturia of endocrine origin. Again, it may be from a solitary duct or from multiple ducts and maybe unilateral or bilateral. So these patients would need triple assessment. Special investigations like ductography, galactography, or nowadays even MR ductography is used. But they are not easily available at all centers. So the usual triple assessment that we do with mammogram or other radiological investigation are usually what we follow. In suspected cases where there is a doubt that there is bloody discharge from a single duct, you can go in for occult blood testing. Management is based on the physiological, endocrine, and drug. If that is the cause, then you just observe. When there is watery, serous, or serous sanguinous and bloody discharge, first you have to exclude cancer and then you can observe. But if it is notorious discharge, then if it is from a solitary duct, you can go for microductectomy. If it is from multiple ducts, major duct excision like Hatfield's operation may be needed. And if there are peripheral ductal involvement, then you may have to do a segmental excision. The next is the involution aberrations diseases. Here, breast cysts, they are important. And again, we discussed that this is a kind of involution because when you result in this and the epithelium are under hormonal stimulation. So these are seen in perimenopausal women. And they present with smooth, discrete lumps, which may be fluctuant or non-fluctuant, and they are usually painful. Again, you have to go in for ultrasound. Triple assessment is again suggested. Characteristic halo is found in ultrasounds, and when you aspirate, you can have straw-colored fluid, opaque or dark greenish fluid, and even you can have debris in the aspirate. Cytological examination is usually not recommended. It is only recommended when the fluid is blood-stained or if there is a residual lump after aspiration. There are two kinds of cysts, simple macrocyst and apocrine macrocyst. The simple ones have a tendency to recurrence is very low, while the apocrine ones have higher tendency, and association with cancer for simple macrocyst is very low, while that for apocrine macrocyst is possible. So treatment-wise, simple aspiration or ultrasound-guided aspiration is what is sufficient. Surgical excision is indicated when cyst fluid is blood-stained or there is residual lump after aspiration or recurrence after 2 or 3 aspiration. And this is one of those that I had excised because this patient had residual lump and she kept coming back with painful lump every time. So we had done an excision on this. Coming to the non-anti-benign breast diseases, mastitis is the most common and breast is inflamed. It may or may not be, there may or may not be an underlying infection. The types may be puerperial or lactational, non-lactational, and special type that is granulomatous mastitis. Most of the breast abscesses develop in the pregnancy, the lactation period known as lactational mastitis, and about 0.4 to 11% of lactating mothers may suffer from this. The non-lactational or non-puerperial abscesses are more seen in the obese and smokers compared to general population. Treatment suggested usually is antibiotics like cloxacillin or erythromycin for 10 days. You can do an ultrasounded guided aspiration of the pus where abscess cavity is less than 3. Some also take 5 as a cutoff. An ultrasound-guided catheter treatment when it is more than 3 is what is suggested. Surgical treatment like previously done IND and debridement is not recommended nowadays unless you see that there is necrosis of the skin or the patient is not responding. The surgical treatment comes as the last resort. This is a randomized controlled trial which compared the repeated ultrasound-guided aspiration versus catheter drainage, and it said that the scarring is less when you put a catheter instead of multiple aspirations. This is again a randomized control trial which has been registered and it is on abscess drainage with or without antibiotics in lactational patient. And this is still going on. And it suggests that you usually would not need antibiotics once you have aspirated the abscess, but we are still awaiting the final results of this. Coming to a very special entity that is granulomatous mastitis, which is a rare chronic inflammatory breast condition with unknown etiology. Clinically, it presents in premenopausal women with firm unilateral discrete breast mass, and it may have associated abscesses or inflammation of overlying skin and fistula, and these may mimic carcinoma. Diagnosis is a diagnosis of exclusion. It has to be excluded from autoimmune and granulomatous conditions like tuberculosis, sarcoidosis, and venous granulomatosis. There is no generally accepted optimal treatment for this. And treatment would consist of corticosteroid, antibiotic, abscess drainage, wide surgical excision, and at times even mastectomy. This would be the rough algorithm where after imaging, if you find granulomatous mastitis, you can start with the high dose prednisolone, not responding in, go ahead with surgery. This is one of my cases where this patient was diagnosed with granulomatous mastitis after I had excluded everything by doing CPNAT and everything. She did not respond to the corticosteroid. Then we excised this, and after that, she really responded well. So looking at a systematic review and meta-analysis of the treatment of idiopathic granulomatous mastitis, it says that surgical treatment has got high complete remission rate and low recurrence rate. But still further investigations are needed to understand it better. There are a few more benign conditions just to mention. Sclerosing adenosis you can usually observe. Duct ectasia reassurance is what is needed. If troublesome, then you can excise the duct. Periductal mastitis, surgical excision of diseased duct alone or total duct excision may be planned. Epithelial hyperplasia, if mild and moderate, without ATPR, no further follow-up. If it is moderate or florid hyperplasia with ATPR, then you have to do close clinical surveillance with mammographic surveillance. So the takeaway message is benign breast diseases are very common. They are not life-threatening, but may be associated with high morbidity and psychological stress. Surgeons should take interest in BBD and avoid inappropriate management. Large proportion of benign breast disease can be managed by listening to the patient and reassurance, reassurance, and reassurance. Thank you very much for your patient listening.
Thank you very much, our foreign guest, Dr. Arunima Bharma, for spending us our valuable time and for the nice deliberation of her lecture. Actually, breast disease of benign tumors bear a great dilemma in breast cancer awareness program. Most of our own having benign breast disease have a great fear of cancer. Most of them with anxiety hampered their familial and social life, which is a nice little told by Dr. Arunima Bharma. Thank you, madam, again. In this gap, I like to request our participant to put their question in our chat box, so we can ask their question to our speakers within short times. And now the last, but definitely the very important topics: screening of breast cancer, Bangladesh perspective. Now the speaker is one of my most favorite person and surgeon, whom I knew from the very beginning of my surgical era. And she is one of those persons who swung my heart to become a previous lady to become a surgeon, none other, our respected professor, Professor Dr. Salma Sultana. Salma Sultana, Madam, Professor of Surgery, Dhaka Medical College Hospital, Dhaka. Madam, can you hear me?
Yes, Sagarika. Thank you. Thank you for the introduction, and thank you Society of Surgeons of Bangladesh for arranging such a nice webinar, a series webinar, I should say, on breast cancer. I'm sharing my screen. Can you see the screen?
Yes, madam.
Okay. So we are observing the breast cancer awareness month worldwide this October, and I was asked to talk on screening of breast cancer, Bangladesh perspective. So the October is, I don't know what is coming on the screen. So October is the breast cancer awareness month, and every year we are observing this breast cancer awareness month. Though we in this year, due to the COVID era, we cannot observe, we cannot do the things properly. Still then, we are doing this virtually. So according to the Globocan in 2018, the number of new cases in both sexes, the breast was 11.6%, and in death was around 6.6%. And it was, breast cancer was the top most 5 cancers. It was the topmost among the 5 cancers, even crossing the cancer of the cervix uteri, which was a few years back, which was the first cancer, topmost cancer in women. And in Bangladesh, according to Globocan, in both sexes, the new cases were around 8.5% among all the cancers. And in female, the breast cancer was 19%, where the cervix uteri was 12%. So breast cancer screening means the examination of a healthy woman for detection of early breast cancer. And it needs informed and shared decision making. Although the breast cancer screening cannot prevent breast cancer, it can help find breast cancer early when it is easier to treat. And early detection remains the primary way to prevent the development of life-threatening cancers. The risk of breast cancer increases with family history. 20% to 20 to 25% women diagnosed with breast cancer have a positive family history. And the actual risk that the family history conveys depends on the number of the relatives affected, their age and diagnosis, having a first-degree relatives in a pre- and post-menopausal cancer. But with the advances in imaging technology and disagreements among the authorities, over recommended schedules have complicated the issue of screening. As with any cancer screening program, careful observation must be given to the risks of developing breast cancer as well as the benefits and harms of the screening intervention, along with the cost involved. Many expert groups have offered their recommendations for breast cancer screening, but much of the controversy lies in the fact that there is not a consensus about when to begin and end the screening, how often to screen, and by what technique. So the guidelines, there are a lot of guidelines like the American Cancer Society, NHS Breast Cancer Screening Guidelines, American College of Obstetricians and Gynecologists, College of Physicians, College of Radiologists, National Cancer Institute, NCCN. All of the authorities have their own guidelines. So there is a dilemma, and there is mixing up of different recommendations. So the screening concepts have 3 components: the genetic screening, then the breast screening, then the cancer prevention. So regarding the genetic screening, in 1990s, germline mutation in 3 important tumor suppressant gene were discovered, responsible for breast cancer and other cancers also, the P53, BRCA1 and BRCA2. BRCA1 and 2 are present in less than 2% of the population. It accounts for approximately 5 to 10% of all breast cancer cases. And women carrying these mutations have a lifetime risk of developing the breast cancer up to 70 to 80%. So when to offer the genetic testing? According to the NCCN guideline, the recommendations for genetic testing to be offered to the individual who has a family history of a known BRCA1 and BRCA2 mutation, personal history of having a breast cancer plus one of the following, like the cancer is diagnosed less than 50 years of age, triple negative breast cancer less than 60 years of age, 2 breast cancer primaries, or diagnosed at any age with any 2 of the following, like more than 1 close relatives with breast cancer less than 50, or pancreatic cancer, or invasive prostate cancer, ovarian cancer, or male breast cancer, or diagnosed at any age with more than 2 close large relatives with breast cancer at any age. So these persons are having a high risk of breast cancer who are offered genetic testing. Next is the breast screening. So the breast screening involves self-breast examination, clinical breast examination, and imaging, like mammography, ultrasonography, MRI, and many other advanced methods are coming up. For women younger than 40 years at average risk of breast cancer, there are no randomized studies done to suggest a benefit to screening. Several authorities recommended a clinical breast examination, that is the CBE, every 3 years, and a discussion about the benefits and limitations of breast self-examination, that is for younger than 40 years. For women over the age of 40 years, the average with average risk of breast cancer, many expert groups recommended clinical breast examination annually. In terms of imaging, the most widely recommended screening approach in the United States for this group has been annual mammography. That is, the annual mammography starting after the age of 40 years in average risk women. But in high risk women, it is started earlier. According to the NCCN guideline, the average risk women clinical breast examination every 3 years from the age of 25 to 39, then annually from the age of 40 years on, and begin annual screening mammography at the age of 40 years, and consider tomosynthesis in case of dense breasts or high risk women. So increased risk women, earlier initiation of mammography, that is less at the age of 35 years, considering of annual MRI, especially in dense breast. For heterogeneous dense breast, recommend counseling on risks and benefits of supplemental screening. Besides mammography and MRI, some supplemental screenings may be needed and it should be counseled for, and full field digital mammography in young women and women with dense breast, those who are at high risk. According to the American Cancer Society guideline, the women with an average risk of breast cancer should undergo regular screening mammography starting at the age of 45 years. So there is a variation between the age of starting the mammography imaging of the breast. Some in American guidelines, most of them are 40 to 45 years, but we'll see it's different in UK guidelines. Women aged 45 to 54 years should be screened annually, and it is qualified recommendation. Women more than 55 years and older should transition to biennial screening and have the opportunity to continue screening annually. After 55 years, they are doing the screening biennially, and 40 to 54 years, it's annually. And women should have opportunity to begin annual screening between the ages of 40 and 44 years. They have the opportunity, but the recommendation is after 40 years, it's annually, and after 55, it's biennially. Women should continue screening as long as their overall health is good and they have a life expectancy of 10 years or longer. And the ACS does not recommend clinical breast examination for breast cancer screening among average risk women at any age. That was the recommendation of American Cancer Society and American College of Surgeons. What about the NHS guideline, National Health Services of UK? Women in England who are aged from 50 to their 71st birthday and registered with a GP are automatically invited for screening for every 3 years. And this screening has a two-part process. Some women will be sent to a normal screening result after initial reading, and others will be recalled to assessment. Further assessment, either to confirm the presence of a breast cancer or a high-risk lesion, or to be reassured that they have a normal result and can be discharged back to the screening. So they divide after screening, the breast, normal screening program. Those who are diagnosed as having a high-risk lesion or suspected breast cancer, they are again recalled and they has further assessment of the breasts. So next is the screening. Actually, in our country, screening, there is no national guideline or national program for breast screening. So we should advise our patients for breast self-examination. I think that is the most important thing. Breast self-examination can be done by the patient and it's very easy, but we have to train the patients or teach the patients to do it properly. So in front of a mirror, they can look into the breast. Anything unusual such as nipple retraction or redness or puckering or dimpling, scaling of the skin should be checked. And also check for nipple discharge, whether there is any spontaneous discharge or not. Then the hand is placed on the waist and pressed firmly, and pull the shoulders and elbow forwards to look any change in normal shape of the breasts by pushing forwards. Then look in the mirror, raised arms and rest behind the head. This allows to see the underside of the breasts. Then place the hand on the waist and roll the shoulder forward and reach into the underarm area and check for enlarged lymph nodes. Also check the area above and below the clavicle on the both sides to see any abnormality. And raise the arm, use the pad. So it is most important that which part should be used for the examination of the breast. That is the 3 or 4 fingers, pads of the 3 or 4 fingers, palmar surface should be used for examining the breast. And 3 levels of pressure should be applied, light, medium, and firm pressure to identify or to assess the 3 depths of the breast. Beginning at the outer edge of the breast, use flat part of the fingers moving in circles. It should be in a circular motion around the breast and gradually making the circle smaller and smaller towards the nipple. And also it is very important to check behind the nipple. Then lying flat on the couch, the arm is placed overhead so that the breast spreads in a single layer over the chest wall, and below the shoulder there may be a folded towel or a pillow. Then again do the examination with the fingers against the chest wall. So these are the superficial levels, intermediate levels, and the deep levels of palpation. Next is the that is the clinical breast examination and self breast examination. Then the mammographic procedure. The recommended tool for the screening of the breast is the mammography. That is, each breast is compressed horizontally between the 2 plates of imaging, and each breast in the the craniocaudal view and the mediolateral oblique view. And the breast is compressed diagonally between the 2, horizontally and diagonally between the 2 plates. So this was a case who came for just a routine checkup. In our country, the people are getting more conscious about the breast, and many of the ladies are coming for routine checkup above the 40 years or below 40 years. And she was advised for mammography. There was no clinically palpable mass or anything, any abnormality or anything. But as you can see in the mammography, the right breast is it's okay, density and everything. The retromammary space, the subcutaneous space, and the breast tissue and the axillary regions. But on the left side, you can see there is an area of density, and there are extensive microcalcifications seen in the mammography, and also there is a lymph node, enlarged lymph node you can see. So these type of cancers can be diagnosed by the screening programs. This one also another case. Patient came for the routine checkup, had no complaint. There is the density in the lower part, it's okay, in the middle part, but in the upper part, if you compare the density of the breast, there is a highly dense area with a spiculated borders, and after the core biopsy, it came as a infiltrating duct cell carcinoma. But the patient had no symptoms. Next is the MRI screening. The role of MRI screening is rapidly evolving. ACS guidelines recommend screening MRI is a supplement to yearly mammography, beginning at the age of 30 for women who have a high lifetime risk. And routine use of MRI screening for general population is not recommended because of the high cost and high false positive rate. Overall, studies have found that high sensitivity of MRI ranging from 71 to 100% versus 16 to 40% in mammography in high-risk populations. So MRI is recommended for high-risk populations, and also MRI is recommended for screening of recurrence after the breast-conserving surgeries. Ultrasound screening. Ultrasound is a complementary tool for mammography. And according to the NCCN recommendation, ultrasound for those women presenting with a dominant mass or asymptomatic thickening or nodularity. The role of screening ultrasound remains controversial. So the mammography is the main tool still now for screening of breast cancer. So the women at high risk of developing breast cancer are those who, with a personal history of breast cancer, therapeutic radiation to the breast area, BRCA positive women, women with a family history of first-degree relatives of breast cancer, and having a suspicious cytology. Next is the cancer prevention. So the modifiable risk factors like for prevention of cancer are maintaining ideal weight, exercising on a regular schedule, and reducing or eliminating alcohol consumption. And several drugs have been studied as chemo prevention like tamoxifen and many others. And the prophylactic surgery, bilateral total mastectomy or bilateral salpingo-oophorectomy may be beneficial in selected high-risk groups. According to a series done in Mayo Hospital, bilateral prophylactic mastectomy showed 89.5% risk reduction in women in breast cancer. So the benefits and risks of breast cancer, the benefits are the screening helps identify breast cancer early. The earlier the condition is found, the better the chance of survival and cure, less likely to need mastectomy or chemotherapy or aggressive treatments. What are the risks? There are some risks also. The unnecessary distress. The many women undergo very stressful condition regarding the screening program. That there may be over-treatment or over-diagnosis, exposure to radiation, and following a screening, about 1 in 25 women will be called back for further assessment. And the breast screening picks up most of the breast cancers, but it misses breast cancer in about 1 in 2,500 women screened, according to the United Kingdom. So the new technologies coming up for screening are full field digital mammography, digital breast tomosynthesis, molecular breast imaging, and abbreviated MRI. So about 3 in every 200 women screened every 3 years from the age of 50 to 70 are diagnosed with a cancer that would never been found without screening. This is the observation of the NHS and would never become life-threatening. So this adds up about 4,000 women each year in UK who are offered treatment they did not need. So every year 4,000 women are diagnosed with breast cancer, early breast cancer. That is the benefit of the UK screening program. So what is the Bangladesh perspective? So in a study published, a review article that was published in 2015, they showed that the prevalence of breast cancer in the last 5 years before, from 2010 to 15, it was 32.8% prevalent in female cancer. Breast cancer was prevalent, and in male it was lung cancer, 13.1%. And another study, it was published in the Mymensingh Medical College Journal, Knowledge, Attitude and Practice of Bangladeshi Women Towards Breast Cancer. In Bangladesh, the incidence rate was found 22.5% per 100,000 females, and the prevalence was 19.3% among the women. And the observation was, this prevalence was between the age of 15 to 44 years of age, which doesn't match with the Western guidelines and Western recommendations for starting screening program in their country. The most of the cases we are facing and also published in Bangladesh are between 15 and 44 years of age. That is one observation. Another, it was a meeting, third Indo-Global Summit. It was in New Delhi in 2015. Mohammad Anisur Rahman Farazi, he's a nurse working in Adelaide. He also have studied, and that his recommendation was that the become a hidden burden accounts for 69% death in women in Bangladesh from breast cancer. And the prevalence was 19.3 per 100,000. And according to his perspective, the nurses should also be involved in the cancer detection planning, total management, and patient and family counseling. And to build up our nurses for taking care of the cancer patients, as well as early cancer detection project is a crying need for Bangladesh. Another paper that is published in Women's Breast Health Research, it was published from Australia and Bangladesh jointly. Awareness of breast cancer and barriers to breast screening concluded that the lack of understanding of the assessment of asymptomatic women is the key obstacle to breast cancer screening uptake in Bangladesh. Health education program, especially breast cancer awareness program, have the potential to increase breast cancer awareness and downstaging of the disease. And from South Asia, the Bangladeshi perspective, they also recommended that, considering all the issues, they proposed that an innovative female-based primary healthcare approach focused on awareness, screening, and early detection of breast cancer in Bangladesh should be started. And their obstacles were there was no system in national health insurance in Bangladesh. Public hospitals are frequently overcrowded, and doctor-patient ratio was 1:3,000. These were the obstacles, though they recommended for a primary healthcare-based breast cancer screening program. And another interesting paper was there. They worked on how the breast cancer screening program or awareness can be generated in the rural level. They recommended for smartphone applications were most efficient and effective in breast health promotion compared with the control group. So till now there is, at present, there is no national breast cancer screening program in our country. There was a cervical and breast cancer screening program that was a project of United Nations Population Fund at BSMMU, and they had conducted the screening program for cervical cancer, I should say, which was a huge success. And that though it had a breast cancer screening program, but the project has ended. I recently came to know. They did some screening centers. They created some screening centers in Bangabandhu Sheikh Mujib Medical University, and also in many of the centers, peripheral centers in Bangladesh. But the project has been suspended, I think ended up. So now there is no screening program in Bangladesh. So my proposal should be, there should be a hospital-based breast cancer screening program under the Department of Surgery. This is already going on in hospital-based, individual hospitals, say in Dhaka Medical College, in NICRH, and I think also in Chittagong Medical College. But it should be covered within a bigger umbrella of the government, so that there should be a national screening program which should cover all the female population, and we should create a national guideline, because as you can see, the prevalence of cancer, breast cancer, is much earlier age in our country. It is less than 44 years, where the recommendation for screening is starting after 40 years. And also, as a resource poor country, we don't have access. We can't do the genetic screenings or any the expensive investigations to our patients. We cannot advise. So we should think, we should solve our problem in our way. And the government should ensure the breast screening tools in every hospital, and public awareness programs by mass media, and also by different awareness programs. Formation of a national breast screening project or program by Ministry of Health and Family Welfare. I think this should be brought forward by this Society of Surgeons of Bangladesh, as is having this webinar, and we should think about our national guidelines also. And I request Society of Surgeons of Bangladesh to take a great action and play the major pivotal role in this aspect. So I acknowledge Professor Muhyiddin Matubar and mostly Dr. Taposh Kumar Das, my registrar, for helping me prepare and gathering data for this presentation. Thank you.
Thank you very much, Professor Dr. Salma Sultana, for her informative presentation. She actually says that developing country like Bangladesh with low technical resources, we have major limits, but there should be a protocol, national protocol, to detecting our ladies at an early stage of breast cancer. Because the ladies from the rural area, they do not know where to go, how to proceed, and there should be a protocol, and there should be a systematic systematic program in every corner of Bangladesh. So this is also my recommendation to Society of Surgeons of Bangladesh. Now we can move to our next session, our question answer session.
I think so many interesting question in the chat box.
Yes.
Please put the question to the speaker or
there are so many questions and comments in our chat box. Sorry, it's the first comments and question from Dr. Noor Hussain Bhuya Shahin sir. To everyone, thanks everyone for participating. He informed us about our two another programs on 21st of this month and 28th of this month. Next question from Dr. Shahnaz Parvin. To everyone, Centroman is very effective in case of mastalgia, but how it reduce the size of the fibroadenoma? She gave the question to all of our speakers.
I think it could be the question to the Aruni Verma.
So Centroman basically is an anti-estrogen. So as I mentioned in my slide that there are ductules from where you are getting the fibroadenomas. They have got a high receptor, estrogen receptor content, the fibroadenomas also. So basically the tamoxifen and Centroman, they are both supposed to increase the proliferation. And that is the way it reduces the fibroadenoma and the size of fibroadenoma. And that is what has been observed. But as I mentioned, that longer studies are required to prove its efficacy.
Thank you very much, Dr. Arunima Verma, madam. Now our next comment and question from Dr. Shakir Ahmed. Thanks to Dr. Arunima for excellent talk. My question is, what is the rationality of mastectomy in granulomatous mastitis? What is the role of methotrexate in management of granulomatous mastitis? Madam, please.
So first is methotrexate is again used to avoid corticosteroids. Methotrexate has also been used in granulomatous mastitis, and I said it is an enigmatic disease. So centers have been using methotrexate with good results. I do not have personal experience with methotrexate because I don't use it with my patient, but it has got similar effect. The infection rate has been seen to reduce. The second question was on mastectomy, right?
Yes, sir. Yes, madam.
So
rationality of mastectomy in granulomatous mastitis.
So there is, like, as I mentioned, it is not that there is any set pattern or there is a guideline for granulomatous mastitis. First of all, you have to try and do a conservative approach. The first approach is conservative. So that is the reason why you use medication. And after that, when there are recurrent fistulas, and it is a very devastating disease at times, like I showed in my case, there were recurrent fistula, and at times, even with a part involved, you can keep having recurrent fistula and deep abscesses. So there are various ways in which you deal with it. Mastectomy will be the last resort, because it is very incapacitating for the female because she continues to have abscesses, fistula, and they keep discharging. So that would be the last resort. But yes, that usually we do not do mastectomy, a local segmental excision. Patients do respond to that. So that is the last resort that we use.
Thank you very much, Dr. Arunima Verma, madam. Another question from Dr. Shahnaz Parvin to everyone. Thanks, Professor Dr. Salma Sultana, madam. When male breast screening is needed, I think she wants to know about the screening procedure of the male breast.
Yes. Thank you, Shahnaz. Actually, there is no screening for male breast cancer. Routine screening is not recommended, but the male breast inherited with BRCA2, if diagnosed that the patient has inherited BRCA2 mutation, those males are screened for breast cancer. they are recommended, but not routinely recommended for screening of breast cancer. And they should do the breast self-examination. That is, I think, for males, that is okay. But if they have a BRCA2 mutation, then they should screen for breast cancer.
Thank you, madam. Our next question is from Professor Rahana, madam, to everyone. Very informative presentation. Well done, Salma. Rahana, madam, congratulate you, Professor Salma. And another question from Dr. Aisha Rahman to everyone. Thank you, Professor Dr. Salma, for informative and elaborative presentation. Thank you, madam. From Shakir Ahmed to everyone. Thank you, Salma, for wonderful and informative presentation. From Sadia Siddiqui to everyone. A good initiative indeed, that would be. From Sadia Free to everyone, thank you, Professor Salma Sultana, madam, for the nice and informative presentation. From Sharmin Islam to everyone, thank you, Salma, madam, for your informative presentation and your great effort. From Shakir Ahmed to everyone, thanks for nice speech. My question is to Tazina, what is the clinical importance of fibrous septum in breast? Tazina, can you hear me?
Yes, ma'am. Thank you, Shakir. It's Dr. Shakira, madam's question,
Yes,
isn't it?
yes. Shakir asks you, what is the clinical importance of fibrous septum in breast?
Thank you, Shakira, ma'am, for your question. As we know all that the fibrous septa of the breast is the main supporting system of the breast, which extends from the skin to the pectoral fascia, and it supports the whole breast. And if any clinical pathologies arise in breast, that it will affect the fibrous septum, and the changes will be appeared in the breast, like skin thickening, or the skin will be puckered. So, main clinical importance of breast fibrous septum is the support of breast, and if it is hampered by any diseases, then the outlook will be changed. Thank you, ma'am. I think you have got your answer.
In our chat box, maximum are the Thanksgiving comments. For the shortage of the time, I only read the questions from our doctors. Our next questions from Dr. Shahnaz Parveen, madam. Is any role of elastography in case of screening of breast cancer? I think it is to the Professor Dr. Salma Sultana. Madam, is any role
Actually,
of
yes.
elastography?
Yes. Elastography is a component of ultrasonography, which examines the stiffness of a lesion. So in screening, actually the screening is targeted for the woman who doesn't have any symptoms or any presentation or any swelling or any complaint. So it is worldwide, the mammography is recommended, the first recommended tool for screening, breast screening. And elastography or ultrasonography can act as a supplemental tool. But I think in our country, in a resource poor country, with mammography, I think ultrasonography can act as a screening tool also. Though we should remember that the ultrasonography is very much operator dependent investigation, and the screening to detect very early breast cancer, actually it is very difficult by ultrasonography. Many of the cancers, I think it will miss many of the cancers. And when there is a lesion is found in ultrasonography, then the elastography can recommend whether it is a benign or it's malignant, looking at the stiffness of the lesion. But as a screening tool, I don't think it should be the first line. Thank you.
Thank
Dr.
you very
Arunima,
much.
do you want to, excuse me, Dr. Arunima, I'd like to request you to talk on this. I think our scenario is same as in India also.
I
Doctor?
completely agree with you. You have very nicely elucidated the role of elastography, because nowadays there are a lot of studies going on for distinguishing between benign and malignant lesion using elastography. But definitely it can't be recommended as a screening tool as of now. I completely agree with you, Dr. Salma.
Thank you very much. Thank you very much, Dr. Arunima Varma, for your nice comments. And there are lots of questions and lots of comments in our chat box, but we are going through our time shortage. So I move to our next session, our panel of experts. Now we want to hear from our panel of experts. Today we have our liaison professor, Professor Dr. M.A. Mojid, sir. Sir, I request you to say something about our program. Sir.
Thank you.
Professor M.A.
Sorry, sir. Little bit, just some. First, Mojid sir is in the last to comment. I think our twin sir,
Sorry.
Shufu sir is in here. So we first take comment from our Shufu sir and the twins. Okay.
Yes.
Shagorika.
Sir. Sorry, sir.
Shufu sir, Professor Shufu sir.
Sir, at first we can hear from our Professor Saif Ahmed, sir. Please, can you hear me, sir?
Shofu, unmute yourself. Shofu, unmute, please.
Sir, unmute, please.
Okay, can you hear me?
Yes.
Yes, sir. I can hear you,
Okay.
sir.
Okay, fine. Fine. Respected chairperson, chief guest, and learned panelists, and dignified speakers, and all participants. Assalamu alaikum. Thanks for organizing this program by SOSB. I'm also a part of SOSB, and really thanks to our President and Secretary General. I really appreciate all three speakers. Anatomy and pathology are the basic for all, especially elaborately and accurately must know our breast surgeon to achieve world-class surgery. I appreciate Dr. Tahsin to elaborate and recapitulate our anatomy, breast anatomy and pathology. Our second speaker, really, Arunima, you know me, I'm Professor Saifuddin Ahmed from Bangladesh. Several times, several meetings, I met you. But really, your presentation is very much helpful for us. Actually, benign breast disease or non-cancer breast disease, 60 to 70%, no need of treatment. Actually, only reassurance and counseling is sufficient to treat them. But in our country, in our Bangabandhu Sheikh Mujib Medical University, we just, in our breast clinic, 70% patient came with a fibrocystic disease. No need of treatment, and we formulate a guideline or we formulate a protocol how to handle this patient and dispose this patient and reassure the patient and benefit for the patient. We organize a breast clinic. Another thing is to know our BSMMU. We formulate step 1, step 2, step 3, step 4. All diseases in breast clinic, this stepwise, we organize this benign breast disease, and step 4, organize a malignant breast disease, and each Professor Salma Sultana nicely presented this thing, but Asian Society of Mastology, ASOMA, in ASOMA conference, we adopted the ultrasonography is the one of the tool for screening program, because mammography is not available in our country, even in the India and other Asian countries. Asian problem solved in Asian way. So we formulate a guideline to screen breast, not only cure the disease, but also save breast, save the organ as well as cure the disease. We, in our Ministry of Health and Family Welfare 2009, adopted a pilot project, and it will run 6 to 7 years. We formulate some guidelines: self breast examination, clinical breast examination, mammography, oblique ultrasonography. And we achieve, and especially it's a pilot project, sporadic, not mass screening program. It's very difficult to our country. But nowadays, in 2020, Mujib Basho 2020, we just introduced it in ministry program. And by this way, we formulate screening program, inshallah, within COVID-19 is just interrupted, but we formulate it next year and to disseminate in our Upojela level, district, and from the central level. We hope to implement it. And thanks to participants, and thanks to organizers, and thanks to my heartfelt thanks to speakers. Thank you very much.
Thank you. Thank you, sir. Dr. Professor Saifuddin Ahmed. Now, our next panel of experts, Professor Dr. Ajit and Mustaq Hussain Tuhin, sir. Sir, can you hear me?
Yes, I can hear you. Can you hear me? Can you hear me?
I can hear.
Sir, yes, sir.
Achha.
Sir.
Respected Chairman of the Chairperson of the session, Professor Tauhidul Alam, sir, President, Society of Surgeons of Bangladesh, Chief Guest, our honorable teacher, our guardian, our mentor, Professor Konak Kanti Borua, sir, panel of experts, among panel of experts, my teacher, respected teacher Mujib sir, moderators, and Secretary General of the Society, Nurushan Bhuiya sir, and our respected speakers. Assalamu alaikum, and welcome, and very good evening. Actually, I must thank the organizers, especially Professor Tauhidul Alam and Nurushan Bhuiya, for organizing such a beautiful webinar in the October month, that is Pink October, that is Breast Cancer Awareness Month. And thanks, and I feel privileged to become a panel of expert here. I must thank the three speakers, Tanzila Haq Khan, for his elaborate description of the breast anatomy, which is the basic knowledge for every surgeon to be known before treatment is breast disease. And Tanzila Haq Khan has explained this very well manner. I must thank Professor Arunima Verma. Actually, non-cancerous or benign breast disease is more prevalent. It's about more than 90% constitutes breast. All the breast disease consist of the non-cancerous or benign breast disease, and but it must be differentiated. It must be diagnosed, and all of we must exclude breast cancer. So it is very much important, and it should be done. It should be done by expert hands, because if we undertreat, patient means life becomes jeopardy. We can miss it, but we do not know. We can overtreat, which becomes a morbidity and agony and psychological problem for the patient. So it is a two-way sword, and it must be delicately handled. And one of the important topics Arunima Verma has in the granulomatous mastitis, which is very troublesome to treat. Actually, there's no consensus about the treatment. And before treatment of granulomatous mastitis, one must be clearly diagnosed. Yes, this is not TB, this is not sarcoid disease, this is not ductal or periductal mastitis. It is granulomatous mastitis. What can we do for granulomatous mastitis? It may be if there is abscess formation, sinus, it may be treated with antibiotic or surgical drainage. But if it does not, it presents with only lump or pain, steroid loading dose of steroid is recommended. And if residual lump is remain, it can be excised. And so on, and ask the question, so whether it mastectomy is rational or not. Yes, mastectomy is rational for reserved peoples, those who the all breast is involved, and not treatment the any medical conservative antibiotic or steroid. It may be simple mastectomy. Regarding lecture of the Salma Sultana, he has clearly elaborately discussed about their screening program. But in Bangladesh, we have no actually guidelines of screening. And though there are many organizations, American College of Surgeons, European Colleges, and NCPN, and even Memorial Sloan Kettering Cancer Institute also has the guidelines. Actually, who should be this? All patients should be not same guidelines. Actually, it has categorized whether the patient is average risk or patient is average above average risk. If the patient has no symptoms, no family history, no history of lobular ductal carcinoma C2, or no history of any atypia, or no evidence of hereditary syndromes, that is BRCA mutation, or no history of radiation in the chest for other diseases. These are the average risks. But any of this is present is the above average risk. And actually, for average risk people, there is a guideline, and for above average this there is another guidelines. Like average is 25 to 40 years annual clinical based examination. Above, if it go for above 40, annual mammogram, or there is Saifuddin mentioned. Can you hear me? Tanjida, mute, please. Tanjida, mute, please. Okay. If it is up to 40 years, annual clinical based examination is enough. But above 40, the annual mammography or ultrasonography, if there is resources available now, especially in the denser breast, that is Saifuddin Shopu has mentioned clearly. The ultrasonogram is also a tool for screening. It is the whether mammography is not available and breast tissue is denser, especially in the younger people or older people who is younger. But and above all, above 20 years, all patients with monthly self breast examinations. But if there is no risk factors or average risk factors, there is no CB, that is clinical breast examination for any age. So, but if it is the higher risk, if it is the family history of breast carcinoma, atypical hyperplasia, or genetic predisposition, or history of radiation, this protocol should be changed and it should be done more frequently. I'll not going elaborate this, but in Bangladesh, we have no protocol about breast screening. We have in Society of Surgeons in 1999, in a conference in the Kumilla and another conference in Nitor, Dhaka, we have formulated a management of breast cancer project. But breast screening was not included that. that documents I can give the society. I think society can go ahead further about with the collaboration of the government or Ministry of Health and DGHLs for formulating a national guidelines. Thank you, sir. Thank you, everybody, for giving me the chance to speak here. Thank you, sir.
A heartfelt thanks to our Professor Dr. A.J.M. Mustaq Hussain Tuhin, sir. Thank you very much, sir. Now, our last panel of experts, our living legend, Professor M.A. Mojid, sir. Professor M.A. Mojid, sir, can you hear me? At first, I beg the apology for my unintentional mistake. Sorry, sir.
No, it's all right. No problem. Thank you very much. Are you all, can you hear me? Am I audible to all of you?
Yes, sir. Yes.
Well, thank you very much. I must congratulate all the three speakers. They gave a very good account of themselves in their respective topics. They have covered everything in their respective topic. And I must congratulate and thank the society for organizing this webinar on a very important issue like creating awareness about the breast cancer. In fact, this topic has been covered by all the speakers so well that there's nothing to add, but I'll still make a few comments about the breast screening, which is very important even in the context of our country. And in the context of our country, this is my feeling that we should carry out breast screening for early detection of breast cancer. And if we can, by screening, detect cancer early, we can conserve breast. In fact, the breast surgery has undergone an evolutionary change over the years because previously Halsted radical, super radical mastectomy, then petty mastectomy, and finally we have come down to breast conservation. And this is very important that if we want to conserve the breast, which is a very precious possession for the ladies, we must make sure that we make an early detection of breast cancer. Am I audible to all of you? Can you hear me?
Yes, sir, I can hear.
Yes, sir, we can hear you.
So this is very important that we carry out this early detection by screening. And how can you do it? In the context of our country, I think we should create awareness amongst the ladies of susceptible age of breast diseases, and they should carry out self-examination. I tell you, this is very important in the context of our country because that will be cost effective. It's not going to involve extra expenses. So first is the self-examination, and if through self-examination a person can detect any lesion, then there should be a clinical examination by a surgeon or by a person. I mention a person because in the context of our country, the patient doctor surgeon patient ratio is small. Ideally, these patients who have detected rightly or wrongly something wrong with their breast, they should be subjected to a clinical examination by a surgeon. And then the surgeon, depending on his finding and his expertise, he can have recourse to certain investigation. And here in the context of our country, for vast majority of screening purposes, the ultrasonography oblique mammography can be done. And all this should be aimed at early detection so that a mutilating surgery can be avoided, because towards the end of this 20th century, we must not routinely do mastectomy. We should try and conserve breast for breast cancer. And only way to do it is to detect it early. And only way to detect it early is screening by self-examination or and clinical examination and mammography. That is how we are going to escalate the stages of screening. And another very important issue that has been discussed by all the speakers, and in fact, it is a nightmare for any surgeon treating granulomatous mastitis, because this is a very difficult issue. And granulomatous mastitis, if it is localized, then there is no problem in dealing with it, because you can carry out an excision biopsy of the lesion. But I think the various treatment that has been offered for granulomatous mastitis, I have got serious doubt in my mind about the efficacy of all this. But this is a consolation both for the surgeon and the patient that she is being given some treatment. But generalized granulomatous mastitis of non-tuberculous origin, that is where there is no underlying definite pathology, it is the treatment is eminently unsatisfactory, both from the points of view of the surgeons and from the patient. And there has been some question raised whether you are going to do a mastectomy. There can be a situation that this is so extensive, the granulomatous mastitis, that if you remove the lesion, you are going to deform the breast in such a way that there will be no existence of the breast. It will be an apology of a breast after you have removed this granulomatous mastitic mass. So in those rare situations, you might have to have recourse to a mastectomy, but that situation is very rare. But I must admit that this is a very difficult problem, granulomatous mastitis. So with this, I once again thank the Society for arranging this webinar and all these three speakers who have presented their respective topic in a very nice manner. Thank you once again. Thank you, ladies and gentlemen, for your kind attention. Thank you.
Thank you very much to our living legend, Professor M.A. Mojid, sir. Thank you very much. Now we are almost at the end. Now I request our chief guest, Professor Kanuk Kanti Borua, sir, Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, to summarize the session and to give some advice to us regarding this. Can you hear me, sir?
Yeah, thank you, Sagarika. First of all, Mr. President of the Society of Surgeons of Bangladesh, Professor Tohidul Alam, Secretary General Dr. Nur Hussain Bhia, and the learned speakers, Dr. Tanzina Haq, Dr. Onurima Bharma, and Professor Salma Sultana, and respected panelists, my teacher, legendary surgeon, Professor M.A. Mojid, my colleague, Professor Mustaq Hussain Tuhin, and Professor Saifuddin Ahmed. And participants, ladies and gentlemen, very good evening to you all. It is my pleasure to be present in this August sessions. First of all, I want to congratulate the speakers for their elaborate presentations of their respective topics. First of all, I want to congratulate Dr. Tanzina Haq for presenting the surgical anatomy and physiology of breast, and Dr. Onurima Bharma for presenting non-cancer breast disease, its diagnosis and management. They have presented elaborately, and there is no room to comment on. Actually, they have so nicely presented their own topics. And Professor Salma Sultana also presented a screening of breast cancer in Bangladesh perspective. Here, I want to comment one thing, that is that I want to give you one information that in Bangabandhu Sheikh Mujib Medical University, one project is running for last 15 or 16 years for screening breast and cervical cancer throughout the whole Bangladesh. And they have included about 200 upazila in their project. And there is a plan to include all the upazilas in screening breast and cervical cancer screening program. But that screening program is not getting momentum as due to there is no involvement of surgeons in this. What I feel, I have advised them to include surgeons, general surgeons in this project. Then it will get is the momentum for screening the breast cancer, incidence of breast cancer in Bangladesh. I hope they will include it. And I also request the surgeons to come forward to help them. I want to congratulate the organizers, President and Secretary, and the Executive Committee of SOSB for organizing this webinar program on breast diseases. This is the month of breast cancer awareness month throughout the whole world. So I think they have done the right thing. And thank you for inviting me. Thank you very much for giving me the opportunity to say a few words in front of you. Thank you all. Good night.
Thank you very much, our Honorable Vice Chancellor of Bangabandhu Sheikh Mujib University, Professor Dr. Kanuk Kanti Borwa, sir. Now, my last request from my side. The request is to our president. He is also the president of Society of Surgeons of Bangladesh, Professor Dr. A.H.M. Tawhidul Alam, sir. Sir, can you hear me, sir?
Yeah, I can hear you. Thank you, Dr. Sagarika. First of all, I would like to thank our chief guest, Professor Kanuk Kanti Borwa. Actually, we get Professor Kanuk Kanti Borwa always whenever we ask him to attend our webinar. He's with us for the last 2 hours, staying here and listening, though this is not related to his subject. Still then, his presence actually really encourages us every time. Verma from India. Her presentation was very excellent. I enjoyed her presentation. I have refreshed my memory from listening many things from her presentation. Thank you, Dr. Aruna. Hopefully, we'll get you again in our future webinar also. Our speaker, Professor Dr. Salma Sultana, she has very nicely elaborated the screening program, particularly in the Bangladesh perspective. And she has also mentioned the lackings in our country. And definitely those who are the policymaker, they will incorporate all these things and they will try to establish a screening program for our country. And lastly, I would like to thank our new moderator, Dr. Sagarika. He has nicely moderated this session, very well moderation. And with these few words, I like to thank our 3 panelists, expert panelists, and their participation, their discussion, their knowledge, everything has definitely enriched this program at a higher level. And particularly my thanks to Professor M. Mujib, Professor Saifuddin Ahmed, and Professor Mustaq Hussain Tuhin for their presence. And we had with us other senior professor, Dr. Mutaleb, and we had other senior professor with us, and they had left the session. And their presence had definitely encouraged us, and they make the program a rich program. And with these few words, I would like to conclude here, and I invite you, all of you, to attend our next 2 webinars related to breast disease, and hopefully we'll learn many things from that webinar also. Thank you everybody for your kind presence. Thank you.
Thank you very much, Professor Dr. Tawhidul Alam sir, President of Society of Surgeons of Bangladesh. Now is the time of ending. As our Professor Salma Sultana Madam says that in our country, the average age of breast cancer is becoming lower. Average age of our breast cancer women is 40 and above plus, near about 44. They are still in their reproductive age, and most of them, my personal experience is most of them have little kids. So they lose their mother at an early stage of their beginning of life because of the late coming of this woman of their breast cancer. So it's time to ending. There is one of my favorite quote. I want to close the session with one of my favorite quote from Martin Luther King Jr., who inspired me overall my life. If you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to moving forward. So there is no time to stay still. We have to move forward. The time is always right to do the right thing. Again, thanks all the participants, especially our living legends, all of our professors, all the participants, and special heartful gratitude and thanks to the Dr. Arunima Varma for spending her some of the valuable time with us. Thank you. Salam and good night to all.
Thank you, Sagarika. I think Rajdevi, please you conclude your official.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe.